after I have removed the flap up and was first suture blood vessels, then I start to suture nerves. And here is the nerve anastomose end to end. I suture them with a few stitches, very neural, and I used to cover them with this neural tube, Neuragen, which will prevent nerve sprouting from anastomose side, and I don't have had any neuronoma-like problems. But because there has been made surgery and many times macrosurgery, so if there are not any free nerve branches available, I don't want to cut any healthy nerve. And for example, here is intercostobrachial nerve, and I have made the nerve anastomosis from my flap end to side. And I make a small window to perineurium, and then I suture this nerve of the flap to the stem of this intercostobrachial nerve, and then I cover it Neuragen to again. And here is the situation in operation table. The breast is revascularized, and here is axillary nerve suture, and the other nerve is inferior side of the flap. And after this pilot study, we started prospective study in year 2006. And we made quite wide sensory testing for the patient. We made it before the operation, and then after 1 year, and after 2 years operation. And we measured clinical sensory tests, 2 points discrimination, vibration, excuse me, salt plant discrimination, and quantitative sensory tests, warm detection, heat, pain detection, cool detection, tactile detection. We took skin biopsies in order to see in microscopic nerve regeneration. And we measured somatosensory pivot potentials, which means that each type of electric response of the breast irritation is recorded from brain waves by using electrodes which are taped on the head. And here are the zones. There we had measure points. For mastectomy skin before operation, we had these 4 segments, and middle of the segment we had measure points. And here after reconstructed breast and the other side healthy breast were measured in 5 zones. And this abdominal skin area was examined from 4 points. And we gave a sensibility score for each different test, and total sensory scores was counted. And the sum of total sensory scores were the sum of individual scores from different tests. And we performed a normal value, the highest and lowest recorded value of normal sensing breast. And that was the define of the limits of the scores. And here are my patients. Now I have 96 free tram lab patients who had participated in the study. They are about 50-year-olds. My youngest patient was 18 years when she got sarcoma to her breast, and oldest patient is 60 years because after this age I use other kinds of reconstructions. And most of them have got radiation and axillary evacuation. Half of them have got chemotherapy, and 3/4 of the patients were delayed MS reconstructions, and 1/4 were immediate reconstructions. And my operation time was on average 7.5 hours, and the size of the flap was 617 grams. Follow-up time was 2.5 years on average. And here is the result. There are the sensibility scores for a healthy breast, and here are the sensibility scores for bilateral or unilateral neurotized breast, and here are to compare those without neuropathy patients. And it is a significant difference, so that with neural anastomosis I can achieve in general half of the healthy breast sensibility. Even there are some who has quite good sensibility, and then others who has not so good. And I'm working on and compare this bilateral nerve anastomosis to unilateral nerve anastomosis, and I have soon ready this publication so we can hear about it later. In our second study, we showed that this unilateral or bilateral neural anastomosis does not decrease sensibility of the abdominal skin comparing to no neuro probe. In general, there is a small area between umbilicus and this horizontal scar. There is diminished sensibility. But we did not have any big pain symptoms. We were afraid of it all the time. And actually, when I counted pain symptoms in this neural group, they were less than in that no neuro group, but it was not a significant difference. And you can see these contours of the rectus muscle. They are normal, and even there is a small part of the muscle away. And this abdominal strength is normal. I have even one patient who have given a baby birth afterwards, after this reconstruction. So the young patients who get this microneurovascular breast, they live along with it, and it works like the on tissue, and I'm very happy if I have got a sensing breast. So I could recommend this for clinical use. Thank you so much for this opportunity.
Thank you, Elena. Thank you very much for reports. Question, пожалуйста, вопросы?
And thank you very much for your excellent presentation. And I have a question, and I hope that our participants have a question for you. And I beg your pardon and ask you in Russian, if it's possible. Скажите, пожалуйста, последние 20-30 лет мы на всех наших мероприятиях и митингах говорим об выборе метода реконструкции. У вас огромный опыт в этой области. Я бы хотел узнать ваше личное мнение. Что вы предпочитаете? Это все-таки лоскуты или же это импланты? И как вы видите будущее вообще хирургии реконструктивной? Это приоритет вы отдаете лично лоскутам или же это импланты?
Thank you for so important question. We can see that implants has become too mode, and the technique with them has developed enormously within my lifetime. And I think every method has its place. So if we have very young persons who has long life ahead of us, I would prefer own tissue reconstruction, because within along the loop we know we can get problems with implants later on too. And when patients' breast will, the weight will go up or high, so this bone tissue reacts with it. And but we have many patients who don't want to make big operations and who are afraid of big operations, then we choose lighter way. And in case there is a suitable amount of tissue in LV flap or maybe some other, so I could choose this before implant. But in case we have very thin patients, which we have, and if they are very much afraid of big operations, then I will choose implants. And I'm very thankful that implants have developed so well as we